Welcome to this educational video aimed at cardiothoracic intensivists on the topic of Fontan circulation. In this video, we will discuss the management strategies for Fontan patients in the intensive care unit. Firstly, the placement of a central line via the superior vena cava, SVC, into the Glenn shunt or pulmonary arteries should be avoided if possible due to the risk of catheter-associated thrombosis and Fontan obstruction. Alternate forms of venous access, such as a midline catheter, are preferable. Normal negative intrathoracic pressure during spontaneous inhalation is a key contributor to pulmonary blood flow and to ventricular preload in Fontan patients. Positive pressure ventilation may have a deleterious impact on lung perfusion, ventricular preload, and cardiac output. When mechanical ventilation is unavoidable, use low-pressure strategies, such as avoidance of PEEP, as well as careful attention to preload and contractility during the period that the patient is ventilated. Early extubation is now considered the optimal management strategy after initial Fontan palliation. Ventricular preload is an important determinant of cardiac output in Fontan patients. Preload is determined by the transpulmonary gradient and by flow through a Fontan fenestration if present. Inotropes fail to increase the stroke volume output of a Fontan patient to the same degree that they do in a patient with a two-ventricle circulation, probably because preload is a more important determinant of cardiac output than contractility in the majority of Fontan patients. Pulmonary vascular resistance, PVR, is also an important determinant of cardiac output in Fontan patients. Even small increases in PVR can result in a decrease in ventricular preload and cardiac output. Therefore, it is essential to avoid factors that cause PVR to increase when possible. In a patient with severely impaired ventricular function, inotropy may be beneficial. However, it is important to note that increasing heart rate may also not be an effective mechanism to increase cardiac output, at least not by atrial pacing. In conclusion, the management of Fontan patients in the intensive care unit requires careful attention to ventilation, preload, and PVR. Inotropes should be used cautiously, and the placement of a central line via the SVC should be avoided if possible. We hope you found this video informative and helpful in your clinical practice. Thank you for watching.